great opportunities there, a lot of different places. Hard problem to solve, but good opportunity.
Yeah, that's great, Scott. And actually, I would add my one possible thing for people to work on. Unlike other industries, medicine is the practice of medicine and the practice of healthcare it fully has to embrace uncertainty. It's embedded in everything we do. When you go to a bank, it's a sure thing what's in the bank account and what the interest rate is going to be, and deposits versus withdrawals. In healthcare, we often have no idea what your life expectancy is going to be. We don't know for sure if your outcome is going to be good after that surgery, and we can't be sure if you're going to be the one that comes down with influenza next week. So a lot of decisions are being made with a tremendous amount of uncertainty. And if those of you who are out there who are brilliant technologists and entrepreneurs can look at this big data problem and use it to reduce the uncertainty, or at least enable people to make better decisions in the face of uncertainty, I think there are going to be a lot of opportunities. And that would be potentially in the worlds of clinical decision support, predictive analytics. Wherever you can reduce uncertainty, it'll help make people make better both clinical decisions and financial decisions around healthcare. There's a lot of questions out there, it looks like, so I'm going to go ahead early and open it up to the floor, so please go ahead.
Yeah, quite a few of you have talked about unstructured data, but as you say, follow money. Money comes only when you pay by code, whether it is a Medicare or whether it is insurance company, everybody is paid by the code. Therefore, that code is the best structured I can see. And why you are saying, can you elaborate your statement a little more on that? And not only, my point is that if the code is there, that is a great structure. The next thing is, if you want to understand the code a little more, then go to the narratives that doctor gets. Therefore, you can formulate accordingly. Thank you.
Yeah, no doubt. So we are in a transformation. It's not going to happen overnight. But let me give you one statistic you can walk away with, and this is little known maybe to most. 1 out of every 3 Medicare beneficiaries is not paid according to codes. Not paid according to codes. 1 out of 3. They're in a program called Medicare Advantage. Think of it simply as HMO style for Medicare, in which the government pays for the care to the health plan one rate, actually every month, but let's just call it one rate. The average for an average Medicare beneficiary in this program is paid $10,000 a year. There is none of this nonsense about giving codes for every single thing you do. Now, 30% of Medicare, I assure you that's not everybody, still 15 million patients. And 25% of United Health, which is the largest health plan in the country, they're no longer paying according to the nonsense of codes, fee for service. They're structuring their contracts with providers according to called value-based purchasing, which is to say some way of saying, I'm not going to pay for everything you do. Take a knee replacement, real quick. So knee replacement, you can go in and you can unstructure that whole experience and say, I'm going to pay for the operation, the anesthesia, the towels, the scalpels, the this, the that, or you could say this, I'm going to bundle it all and pay the doc one fee. And you're on the hook. If you decide to put in a very expensive transplant, knee prosthetic, that's you. If you decide you want an anesthesiologist gold-plated and put in all kinds of expensive drugs, that's you. And you want to keep the guy in the hospital for 10 days afterwards, that's you. But that's going to get us away from it. Now, certainly, I'm all about following the money. So you can follow that for those that are on the fee-for-service track. I'm saying if you're an entrepreneur and you're looking at where the puck is going, not where the puck has been, to use a hockey metaphor, then you just want to go to where we're going to evolve as a system. And ACA or Obamacare is getting us there.
Jonathan, would you use coded billing data to help in your care for patients or creating a learning healthcare system?
It's tempting to try, but unfortunately when you do take the next step that you mentioned and going back to the documents and trying to reconcile, how does this code actually relate to this patient, unfortunately you find out that the codes really are used for the purposes of billing, which doesn't always describe what's happened with the patient very well. Somebody could have been thinking perhaps this patient I'm ordering an MRI scan because I'm worried that this patient has a tumor. So they put that code in, and that gets passed into billing, but the patient never had anything. That actually happened with e-patient Dave, if you've heard of his blog. I think in one of the Boston healthcare systems, he got a list of his diagnoses, and like a third or a half of them were things he didn't have, and like awfully devastating diagnoses.
Yeah, we did an analysis of codes for a company that provides a diagnostic test, and it was interesting just in terms of the variability of A, how it was coded, getting to this notion around the uncertainty of things, and B, the reimbursement was very different depending, and because you could code multiple different ways and you could use multiple codes because depending on the procedure it gets complex. Very different pattern of reimbursement by payer based on the order in which you did the codes. So again, an opportunity with structured data, but high variability within that.
You'll consistently see the codes most frequently used are not necessarily the codes that link the patient condition, but the ones that reimburse better. Because they're reimbursement codes, so everyone's trying to game the system to get better reimbursement. And in some cases you have, coders, there's this whole army of coders, these people whose job it is to sit and read through records and who in some cases have high school education and nothing more, and maybe a couple weeks in a coding class, who are making their best guess based on a physician note what the patient had. And the physician says, well, I ruled out, myocardial infarction, heart attack. Well, they put myocardial infarction as the They look it up in their book and they put it down. And so that's kind of what happened with e-patient Dave. They were trying to rule out a tumor, and some untrained, unskilled coder said tumor, and then that got in there, and that followed him through his healthcare record. Then you have insurance companies making coverage decisions based on these things, and you have life insurance companies making decisions based on the fact that because some 20-year-old coder made a mistake, following forever. And so it's always been the low-hanging fruit because it is structured data. It's more readily available, but unfortunately, it's been plagued by great inaccuracy. David.
Hi, Justin. Dave Snyder, 42 Tech. The thing about rejecting the use of claims data for those reasons, it's not unique to claims data. It's actual medical record data that is dirty. Because suppose you were prescribed something, and this happened to me, you were prescribed something, here, try this, see if this helps. Okay, I tried it once, it didn't agree with me, or it didn't help. Great, that prescription is in there. I had to actually ask my doctor to specifically remove it because I knew it was in there because I looked at the patient portal and saw it was there, and I know enough to ask about it. Most patients, that would just be lingering there, and that's the physician entered and pharmacy entered data. That's not your claims data. So the electronic medical record itself is dirty data. And when you start doing these analyses and you start going in there, I'd like to hear you comment on how you're going to account for those things.
Yeah, a lot of the prep work is in scrubbing the data, no doubt about that, in terms of being able to look at that, identifying outliers, doing it in a semi-automated way, so that you can at least get one level of pass before then you hand it off to somebody who has the intuition to be able to more correctly, accurately identify.
I would say this, so depending on your use case and how you're using the data, you're going to have a certain tolerance for noise, and it's going to have to be probabilistic, right? So if you're getting down to refining, that this person on this day got this drug, and I'm going to do something based on that, your tolerance for noise is going to be much smaller. And what you're trying to do, perhaps, is not maybe able to be done, depending upon your threshold for what you're going to be safe to do. Now, across a patient chart, across numbers of patients, to do something more at population level, then that noise you can start to cancel it out. So I would say it definitely depends on what you're trying to do. You certainly cannot attend in every case for the errors that are going to be placed, because this is a human endeavor. But certainly mining richness and data going beyond certain aspects of the data layer is going to get you further faster than it would be the case if you're just mining the topsoil, which is coded data. Coded data is the topsoil of terra firma, which we call healthcare record, right?
I just want to point out one other area of great challenge when you deal with healthcare data is the fact that we do not have unique patient identifiers. And so we're in this great move to try to create health data exchange and interoperate between healthcare systems and create unified databases. But of course, this is very messy data, and we don't have standard identifiers, and so we're having to do some level of probabilistic matching. But it does run the great risk that you carry over data from inappropriate merges. It's compounded by the fact that there's people in the healthcare system who go seek healthcare who deliberately obscure their own identity. They don't want their employer to know that they have HIV. They don't want to know that they've been admitted for depression. So maybe they're an illegal immigrant. And so we have great difficulty doing matches of data, and that may be the case in the financial services industry, or getting your credit score. But the worst that might happen is you might get rejected on a loan. But in this case, you might actually be inappropriately treated for a disease you don't have, or inadvertently get exempted from treatment that because maybe perhaps people think that you've expired in the hospital when you weren't in the hospital at all. So another very messy angle.
Just have a.
Your unique identifier, patient identifier. Can you explain your unique patient identifier, that word that you use?
Oh well, there is no unique patient identifying number. None of us have a patient ID that we walk around with. Yeah, like the Social Security, but we no longer can use Social Security in healthcare. They've asked us not to use it anymore. So there's no number. When you walk in the hospital, they don't say, "Give me your patient ID card." That you register, but the person with the same name as you in the next hospital down, who may have a birth date that's very similar to yours, maybe they inadvertently get mixed. So.
But your social security number, that is identifier.
You're not allowed to use it anymore in healthcare. Yeah. Someone has the microphone.
I just want to. My name is Sagar. I work with Scott in Summer Technologies. I want to make a comment and see if the panel agrees. One opportunity for most of the young entrepreneurs here is syndicated data. It is structured, but is out there, freely available for us to analyze. Data from CMS, data from OpenGov. Tremendous amount of data today is available on healthcare in public domain. But a lot of business units, hospitals, and other places, companies, businesses do not understand that. So it's a great opportunity for us as entrepreneurs to actually use that, analyze that, and provide statistical, predictive, analytical applications on top of the data. Do you agree?
Yeah, my former company, that's what we did. And that's a great, rich source. It's getting richer, it's getting greater. The largest funder of research is the NIH, and if you get an NIH grant, then by the terms of the grant, you have to make that data public, your research public. Downside is there's no necessary structure or format to it, and so my former company did a lot of work in terms of understanding that data, matching it, being able to then use it to do predictive analyses around population outcomes, those kinds of things.
We have another question back here.
So lot of this claims data or other data that is being talked about, I do not see that as big data. I see that as more of a BI, business intelligence problem. The question, somebody said on the panel, follow the money. Some of the most expensive parts of the healthcare system are the physicians, the nurses. And there's this concept of second opinion. So normally if I want a physician's diagnosis cross-checked, I go to another physician. Do you see technology taking over that second opinion role initially, and maybe later on technology becoming the first opinion and the physician becoming the second opinion?
Oh, I'm going to be out of a job here, huh?
No, you've got both jobs, remember?
That's right. I'll just up my percentage of IT time then. I think that's a pretty interesting idea, and I know there's some work going on now with a couple startups I've seen around even using non-physicians as the first source. So using the wisdom of the crowd to, say, narrow down a diagnosis of just people who are kind of interested in researching your symptoms and coming up with a list of possible diagnoses. that could help sort of streamline the process and maybe avoid a bunch of diagnostic tests that are expensive and potentially fruitless. So I guess I would hope there's some convergence to getting to the right answer more quickly. I think the nature of healthcare, in my understanding, I mean, I haven't been in this business all that long, but my father's a physician, and it seems to me the types of patients in the hospital now are very different from the types of patients that were in the hospital 30 years ago when he was beginning his practice. So I don't think there will ever be a time where physicians and nurses and inpatient care is totally not required, but there is probably an opportunity to get on the right treatment path more quickly.
So here's a couple statistics to keep in mind. So, one, we're going to add 20 to 40 million patients into the healthcare system who are now going to have access to healthcare who previously haven't, and in some way, shape, or form, they're going to now seek care. Two, we have hundreds of thousands projected shortage of physicians across the United States. Three, well, that's a big problem. So where I see technology helping is assisting care extenders. So where I see this whole medical practice going, and I'm not sort of unique in this perspective, is that physicians become kind of the quarterback of care, and you're trying to create a whole team of physician extenders and others to do some of the work that maybe physicians can sort of outsource, delegate, divide and conquer, where technology can help those less trained to be the ones to really understand, well, what to do. So you walk into an internist's office, and some of the care can be, well, I'm going to titrate your blood pressure medications and cholesterol medications based on that visit. Well, that's probably something a nurse extender could do or someone else could do, so that physician could spend his or her time doing other things that are sort of higher order level of thinking, practice at the top of your license. So technology could probably help with that. Not necessarily, in my view, for the second opinion. I think it's more about how we're going to make do with less in a system in which we're going to throw many more people to access a system that doesn't have the capacity to meet the demand.
So, Mike, it's a two-part question. One is the access to the how does privacy laws, etc. If I'm a data analyst and I want to access whatever data that I'm trying to do analytics on, how do the privacy laws prevent me from actually accessing the data, especially if the patient wants to keep it, whether the syndicated data or whatnot. So that was the first question. The second question is about wasted diagnostic. There's tons of millions of dollars that are wasted on MRIs and CAT scans and things like that. That I think one of you alluded to earlier, and they realize that it's all wasted money. What's your opinion on how analytics can predictively prevent wastage on diagnostic tests?
I'll start with the second question and kind of go back to something that Justin mentioned before that has to do with the sort of inherent uncertainty in healthcare. And I think that also doctors probably don't know enough about statistics and prior probabilities, because what we do, the royal we, I guess, it is often order tests based on fear. What's the worst thing this could be? What do I not want to miss? Regardless of whether the chances are exceedingly low of that being the case. So, being able to show a person, even if it's a simple lab test and not a $5,000 MRI, to say you don't need to order this lab test because you see somebody with a fever and a rash and you think of this problem and you worry about it. The prior probability is so low, it doesn't matter if that, what the sensitivity and specificity of that test are, it's going to be useless for you. So I think that's an opportunity to decrease waste in the system, is by arming people with that information.
Isn't litigation sort of the back end of that? When the patient is non-diagnosed, that one exception comes back to sue them, which is one of the reasons there's this cover your ass mentality to do all tests.
Yeah, I think that's true. I'm fortunate to not have been in practice long enough to be sued yet, and still hold to the belief that if you practice good medicine, that's the best defense for getting sued. if you're armed with the data that these are the chances of a person having a problem, I think you'll be making better decisions most of the time.
Unfortunately, of course, medical malpractice juries don't understand statistics either, so we do see a lot of defensive medicine practice for exactly that reason. Did anyone want to address the privacy question, or I can address that specifically to?
Go ahead.
Yeah, so you ask a great question. There are special protections afforded to healthcare data, just ethically, but also by federal statute. There's a statute called HIPAA. Most people have probably heard of HIPAA, the big scary HIPAA. 1P, 2 A's, just so you know, 1P and 2 A's. And HIPAA does many things. That's a very complicated law, and I don't want to go into a great detail about it here, but essentially it affords special protection to healthcare data and assures that those who are accessing it have to take special precautions with it, and essentially asserts that patients are, in the end, the owners of their medical data, and all others are stewards of it. And that stewardship, in theory, although it's not explicitly laid out in HIPAA, in most cases it needs to be conveyed with the patient's consent, or in some cases implied consent. Some places that consent can be given. But so it's going to depend on the specific use case that you're planning to do with the data. Now, in most cases, we're talking about identifiable data that can protected health information that can be linked back to an individual. So if you're looking at aggregate data, that's not protected under HIPAA. If you're looking at data that's been completely and thoroughly de-identified, and that's another topic as well, that can't be re-identified, then that is no longer protected by HIPAA either. So it's really data that can be linked back to individuals. So.
You can't run analytics on patient records.
What's that?
If you don't see.
Wait, so we do this every day. I've got sitting in my cloud, fully identified data, encrypted, okay?
Yeah.
Fully identified data for millions of patients for 10 years. Why? Because I've convinced a health system. So when you walk into your physician's office and you sign the note, you're signing away under HIPAA that affords you the ability for that health system to do with that data things related to the quality of care, treatment, or sort of financial related, simply stated. I'm not a lawyer about HIPAA or anything. So if you work with a entity that you're so fortunate to, say, I'm going to provide for you some analytic services for you, then you can have a agreement essentially that enables you as a business associate to do work on fully identified data so long as you provide the required HIPAA type of protections. So, but you need to convince, that owner of data, that health system, hospital, insurance plan, for example, that you're going to afford all those protections and do it. So don't get depressed. You just have to then go and have a value proposition that's going to enable somebody to then say, I'm going to give you the rights to that, not the rates, but the ability for you to work on that data. Unless, of course, you want to go and purchase the identified data on the open market, or Medicare will give you 5% of their data and have at it, and then you can sort of create your business.
Right, but once you start handling that identifiable patient data, then they're going to require you to take all kinds of precautions. Many health systems have now been burned by bringing in contractors or companies who leave data on unencrypted laptops in the subway or whatever. So, and they're getting fined and publicly shamed for that. So they're watching their vendors very carefully.
Yeah, and the syndicated sources that are out there are de-identified. So you're not going to be able to just go out on the internet and pull down identified data.
Hopefully. It's happened every once in a while, unfortunately.
Straight laptops.
Next question.
Yeah, is there anything out there for the consumer? Let's say I'm somebody who has a fairly run-of-the-mill disease, I need an operation, and I have 4 doctors to choose from. Is there anything, and it seems, I've asked them, hey, what's your hit rate? How many have you done? They don't even know their own stats. Is there anything that could enable the consumer to make better choices?
Scott, you want?
I mean, there's a number of sources, and depending on the provider, they will often give those kinds of stats. A lot of them choose your physician kinds of things. There's a lot out there that you can go and do the research and identify whatever disease you have, whatever condition you have, whatever treatment you're trying to get. who's done it in your area, et cetera. And that's a lot of the rating kinds of things that we have that we have on our patient satisfaction side of things.
Jonathan, how would I, if I had a sick child and I had to choose among the various children's hospitals, why would I choose Lucille Packard? How would I make that decision?
I guess hopefully there wouldn't have been a recent report of a data security breach in the paper, because that's not very confidence inspiring. I suppose there are many external places we report our data, U.S. News and World Report being one of the ones that's more public. I think unfortunately that it looks very good that our neonatology unit is in the top 10 nationally there, but so many of those things are based on kind of research dollars and things that don't necessarily relate to patient care, that it's good publicity, but not sure that it is that helpful in making a decision. I think talking about the volumes that people do is a pretty big deal. For instance, I've had many friends ask me, who's the guy at Stanford that I should have, do some relatively run-of-the-mill surgery. And I say, well, I think you should go to the community hospital that does like 10,000 of those a year and have it done there. So, so I honestly am not sure about a way really for consumers to feel better about the quality.
But you can, I think as of October 1, data will be available to customers, consumers, to choose between hospitals on the cost of that care. So for example, if you're having a knee surgery, I know 2 or 3 startups that are working on this to give you costs. What does it cost in Stanford? What does it cost in El Camino? What does it cost somewhere else? How good that care is, you'll have to decide.
Well, and also, unfortunately, most consumers are insulated from that true cost. You pay your copay, and it doesn't matter if they're charging $20,000 or $50,000 for the knee replacement, which could be the case across the street for no reason. But you may just pay your $1,000 copay no matter which place you go to. So, unfortunately, the depressing state of the situation is that there aren't good places to turn to for consumers to make those decisions. I think that's well recognized by CMS. They're actively trying to get more and more data out there publicly for consumers to make decisions with websites like Hospital Compare and Physician Compare, where publicly reported quality information is posted. But to get data on the quality of care of an individual physician, you can look at Physician Compare to the extent that some of that's reported. That's not always the case. You can't really get volumes of surgeries. You can at least get a feel for an individual hospital's systems by looking at their patient safety events, patient safety reporting. Because when you have that procedure done, the doctor's actually only a very small part of your overall care. There's this whole network of providers around you that are providing you care that are just as important or even more important than the actual physician. And if you're in a place that doesn't have good systems and can't manage to prevent what are called never events, they're events that should never ever happen, or you can't make an excuse that it was a rare case, they should just never happen. Like leaving an instrument in a patient during surgery should just never happen. So that is all now publicly reported, so at least you can get that information on your health system. But it's very challenging. My colleagues, my friends ask me, which doctor should I go for this or that, and I say, I don't know. This person seems nice, but.
So here's an entrepreneurial opportunity. Let's just think about this. So we have a healthcare system in which most data that's readily available is claims and only costs, and that doesn't help. We don't really have good understanding of quality information, and all of it relies on text data. So how about transparency tools that makes the market work? I always say I know more about the car than I'm about to drive to go home right now, than I know about the physician I'm going to see to provide any kind of care that we're about to retrieve. Now, the payment model changes may help, but transparency, right, cost and quality, because its value is quality divided by cost, right, not just cost. And so certainly there's a lot of reasons why consumers don't have a real reason to figure that out, because it's called the free buffet of healthcare, which is our current system of employer-run insurance and all of that. But really, that is an opportunity. It's not greenfield, but I'm saying if you can get your hands around good understanding of value of care and provide those report cards to consumers and others that pay for health care, well, in them Dar Hills, that's an entrepreneurial opportunity. I'm not saying it's easy, but it's most sorely needed, and the only way markets work efficiently.
So if I could jump in there, one thing, and I've been working with a few startups that are tackling this issue. One thing that happens is in the absence of good qualitative data or clinical data about how the care is being delivered, people are talking online using social media, they're rating their doctor, they're tweeting about it, they're posting updates on their friends. And now consumers, in the absence of a subjective data, are looking at that to determine which doctor they're going to go to. And I work with some surgeons who do 6,000 surgeries a year, and they have one negative review on a website because the nurse was rude to them, or something else happened, the air conditioner was broken when they visited, and that's out there. And now the surgeon is getting rated based on that experience. So how patient experience is affecting the choice of the hospital or choice of which doctor you go to is a major issue for the doctors. And then are you going to look at just the quality of care data that the hospital is tracking, or are you also going to look at the patient reported outcomes? And that was another question that I was meaning to ask the panelists, which is, health doesn't happen when I go to the doctor or I'm in the hospital. Health happens between visits, before that encounter and after that encounter. So how do we look at the patient reported outcomes? How do we normalize that across multiple systems? And I work with doctors where some of the data is missing, and in some cases, if I come go overseas and have some tests done and bring those test results back, for various valid reasons, the systems can't accept it. So that basically is a major, I would say, entrepreneurial opportunity on how do you add transparency to the patient satisfaction or the quality of care and the experience, and help that in terms of allocating, sending people to the right doctor.
Agreed.
Yes, this is for Darren. You talked about value-based reimbursement. Who is providing the metrics to measure the value, and when will they be adopted? And will it be standard throughout the US, or is it all regional?
Right, so good point. So value-based purchasing is, it's funny, there's two aspects to it, and I'll get to some of the ways without getting too deep. So one is, like I said before, we're going to pay a fixed fee for the care, and it's shifting risk, right? So now the provider has to provide value, in terms of being able to, within that certain amount of money that's being given, I'm going to now provide the best value of care. So within a lot of those contracts, there's also some quality provisions or metrics that you have to achieve. Because imagine if I only give you one fixed sum of money and there's no quality metrics, you're going to then just under care for the patient, because you're going to try to get as low the cost as possible to keep the biggest margin you can. So there's quality metrics. Are they perfect? No, they're the sort of basic common denominator, because it's mostly predicated on what's the easiest data to collect. Why? Because again, healthcare is behind in the way they're using data. They're using claim data, and they're asking, well, did a diabetic get a foot exam? I mean, diabetologists do a lot more to diabetics than whether you got the foot exam. It's a lot of process-oriented measures, not the outcomes of what you actually achieve for the patient. But again, it's a starting point. So value based on the quality, and then I'm going to make sure that the cost is reasonable. We have a long, long way to go. Quality measures and the way to determine performance of physicians in its infancy. And people have tried pay for performance. I'm going to pay docs more for better quality of care, but we have such little metrics that are valuable. I can't tell in the claims data whether neonatologists are better than another, because most of the data that really tell me whether a neonatologist caring for the premature baby is better than another really is in that deep data. That's what I'm talking about. That's big data in healthcare. That's where the people, one of these folks in the room, are going to crack the nut on figuring out how to figure out which neonatologist is providing better value care for the outcomes of that preemie. That's going to be truly what we need.
Well, and it's even a little more complicated than that, because, unlike determining quality on an assembly line or for work, every patient is a little bit different, and we don't have we have okay but not fabulous risk modeling. So I may see 10 patients, and someone else in my specialty may see 10 patients, and my patients may do worse, but it's just because I get I happen to be at an academic medical center where all the worst patients get referred to, and so they're already on a bad course to begin with. And so I may look like a worse physician because of worse outcomes, but of course I'm taking more risk. And how do we actually quantify that, and so to actually demonstrate that that's so pull that out. That's why we have a lot of quality measures that are process measures, because process measures are sort of unambiguous. You definitely should always elevate the head of the bed while the patient is in the ICU. We know that prevents pneumonia. We can't even define what a pneumonia is in the ICU, believe it or not. There's a big controversy about what constitutes, so they've had to completely give up on measuring, because you get 3 physicians in a room and you get 4 opinions on whether it's pneumonia or whether it's an adverse reaction to the vent or a lot of different. So they've had to toss that out, that outcome measure, but they can do all the process measures along the way. So it's a long road. It's going to be a long road. There's a lot of people trying to come up with metrics, and if you think about the fact that every medical condition is actually a different service line in many ways, and every service line is going to need multiple metrics. It's going to be the electronic metrics that we're going to need, the metrics that we're going to need just in general, even if we use data or not, automated or not. We're talking in the many, many thousands to evaluate healthcare, to get down to the level of subspecialty of a neonatologist. It is something very unique that there's nobody else in the hospital and in all of healthcare who does anything as specialized and unique as the neonatologist. It's not comparable to anybody else's workflow. Same with the ophthalmological surgeon. Is so radically different from what anyone else does in healthcare. There's no metrics for them that make any sense, except for very specified metrics, and we have a long way to go before we get those. Are there a lot of metrics yet in neonatology?
No, I mean, like, wash your hands when you're putting in a central. I mean, seriously, that's where we are in terms of the process measures.
I completely agree. Risk adjustment, risk assessment. My patients are different. Especially the patients like me, kind of the analysis that was shown earlier about how to treat lupus patients, that could be tied to how do you risk adjust for appropriately to know this physicians with these patients with this profile ought to be accounted for and scored, if you will, in a particular way. Totally agree with what Justin just said.
Question. Most of the research, if you look at JAMA, if you look at all the research that the physicians go to, seem to be based on the white population and the white male population. What are we going to do with the country changing its demographic, and how is medical care keeping up with this?
Yeah, so I would say, as a member of an admixed population myself, my mom's Jamaican, my dad's Caucasian. I don't know what to make of my 23andMe results, to be honest with you, but when you're talking about genomic data, I believe there are 6 or 7 different populations that are pretty well studied that are, non-admixed, but contributing to GWAS studies and things like that. But a point that I would make is that I think we're shifting from this era of evidence-based practice to practice-based evidence, where we're doing things like similarity matching, and so one of the things you might match on is ethnicity for a patient with a given condition, and looking at the outcomes for those patients to make a decision for your patient at the time. Because you're right, I don't think evidence-based medicine will ever answer all the questions that exist in clinical medicine.
And I was talking about the major studies like the Framingham Heart study.
Sure.
There's been no other study for any other ethnic group or any other variety. So pink, blue, green people are always excluded.
Well, yeah, I mean, unfortunately, I think, that's the best evidence we have, and it's not exceedingly generalizable. You're right.
Scott, are you seeing variations? Can you infer or extract that socioeconomic and ethnic data out of what the data you're looking at in the public tweets and other things?
If it's disclosed, but often not, so being able to do that's tricky. I will say, again, based on past lives, there is a lot more going on, particularly from the pharmaceutical side, in terms of the kind of clinical trials that they're having to run for specific ethnic populations to be able to get indications and drugs in external markets, that data is now flowing back in terms of what you look at in terms of it's being analyzed by FDA and other people to say, okay, do you have to include something on the label to either include or exclude a given ethnicity, et cetera. So I think it's getting better, but you're right, it's predominantly not there yet.
Take this medicine if you're not.
So here's a thing that's actually going to revolutionize the way we understand. First of all, I totally agree. Most of the practice of medicine is not evidence-based, period. It's expert opinions and people that get around and fancy resorts and ask questions. How would you do it? How would you do it? And you write a book and you say, Brumwell's Secrets to Heart Treatment. But the idea is the following. So clinical trials has been the way in which primarily we've understood how to care for patients, in the U.S. and around the world. They're increasingly expensive. Increasingly, the system is broken for how to understand, the best ways of treating care. Luckily, and again, big data in healthcare, right? Now we can take data on millions of patients and create what I call a back to biology phenotypic picture. I'm going to now take your longitudinal record, I'm going to understand that deep data, I'm going to create a vector, mathematical representation of you, then I'm going to compare that vector to someone else's vector and say, in these similar patients, I'm going to run virtual clinical trials. And I'm going to now understand how that medication used in these particular populations that have now been sort of case controlled or matched, and statistically you can do it similar to a randomized controlled trial that giving you all the mathematics. You can start running just totally paradigm shifting types of studies without going to the expense and time and effort of enrolling 5,000 patients. So there's folks at Stanford doing this right now, and in ways in which it's totally going to disrupt the practice of medicine. I totally agree. In the African American population, the way in which you treat hypertension in particular ways is totally upended, or heart failure, from the way in which you would consider based on